to welcome every one of us to the sixth webinar series in the clinical neuroanatomy course that has begun now. So today we'll be having a medical student from Zambia presenting to us the arterial supply of the brain. So what we're just going to do now is that every one of us is going to introduce ourselves. I'm going to start by introducing myself, then I'm going to just call us based on the names here as it appears on my screen, so that we'll all introduce ourselves and then we are going to start. So I am, my name is Tunde Olobatoke. I'm a fifth-year medical student at the College of Medicine in Nigeria here, and I'm a member of AFAN and a research fellow at AFAN. So I will just call us now as it appears on my screen so that we can also introduce ourselves. I would love that we do that very quickly so that we'll be able to move on to the webinar. Okay, so Darwin, can you introduce yourself?
Hello, good evening, everyone. Thank you so much for being here. My name is Darwin Chemba. I'm a final year medical student at Copperbelt University School of Medicine in Zambia, and I'm the current president of the Association of Future African Neurosurgeons. It's wonderful to be here. Thank you so much.
Thank you, Darwin. You're welcome. Okay, Bejo, can you unmute and introduce yourself?
Greetings, everyone. I'm Bejon Dongmuta Singh, Director of Operations at the Association of Future African Neurosurgeons. I'm happy to be here with you guys today. Thank you.
You're welcome, Bejo. Thank you. Ebenisha, can you unmute and introduce yourself? I think it's not there. Can we have Mohab Helmadi? Can we have him introduce himself or herself?
Welcome. Hi, everyone. I am Mohab Al-Mahdi. I'm a neurosurgical specialist from Sudan, from University of Khartoum. It's nice to meet you, and it is the first time to attend your meeting, and I hope to make a good collaboration with you. Thank you.
Oh, you're welcome. Thank you, Dr. Mohab. You're welcome. Okay, can we have Neontu Sakaiwa? Can I have you introduce yourself?
Hello, everyone. My name is Neontu Sakaiwa. I'm a fourth-year medical student at the University of Botswana. I'm also a AFAN representative for Botswana and part of the AFAN communications team and one of the new research fellows in AFAN. Thank you.
Okay, you're welcome, Nyanto. Can I have Mustafa Mubarak? Can I have you introduce yourself?
Yeah, I'm sorry. I'm not really feeling well, so my voice. Thank you. My name is Mustafa Mubarak. A 200 level medical student in University of Ilorin, Nigeria, and a newly admitted member of AFAN. Thank you.
All right, you're welcome, Mubarak. Can I have Wak Solomon Charlie? Can I have you introduce yourself?
Good evening, everyone. This is Charles Watson Nokera, a third-year medical student at the Copperbelt University, Zambia, a member of AFAN.
You're welcome, Charlie. You're welcome. So, can I have Lando Elvis? Can I have you unmute and introduce yourself? On my screen here, it appears he has not connected to the audio. So most likely he's not able to hear us. Because of our time, I will move on to Dr. Andrew Alalade. You're welcome, sir. Can you introduce yourself?
I was hoping you wouldn't ask me to introduce myself. Good to hear everyone today. I was trying to check who was doing the presentation and I couldn't find out any names in the group. It's Alalade here, consultant neurosurgeon at Royal Preston. Being a part of the group, love to see a lot of you guys avid neurosurgeons of the future. So I thought I'll come and have a bit of a peek in today and contribute a few things if necessary. Thank you.
You're welcome, sir. It's an honor to have you in our midst. Thank you very much. Okay. I will leave the floor now to the presenter today. I'll allow her to introduce herself and then she can start our presentation.
Good evening, everyone. My name is Musankaya Shitulika, a final year medical student from the Copperbelt University, Zambia, and I'm also African country representative for Zambia. And I'm glad to be here. Today, I'll take you through the arterial supply to the brain. So our plan is as follows. We're going to do the introduction, the generalities, the descriptive anatomy, the clinical application, and we'll conclude. Okay, so our objectives for today is to know the arteries that supply the brain, to know the blood supply to the regions of the brain, to know the conditions associated with disruption and rupture of the arteries of the brain. Okay, so the brain is one of the organs in the body with the highest oxygen demands, and it represents 1/5 of the body's total oxygen consumption at rest, and about 15% of the cardiac output is utilized by the brain. So the brain is sensitive to oxygen deprivation, and ischemic cell death occurs within 5 minutes of oxygen deprivation. So this is just a picture showing the arterial supply to the brain, which we'll look into details as we continue the presentation. So when we look at the blood supply to the brain, the two main arteries that supply the brain are the vertebral and internal carotid arteries, and these are paired arteries that arise in the neck and ascend to the cranium. So the internal carotid originates at the bifurcation of the left and right common carotid arteries at C4, while the vertebral arteries arise from the subclavian arteries. So this is just an image showing the origin of the internal carotid and the vertebral arteries. So these vertebral arteries arising from the subclavian arteries, and then we have the left common carotid arising from the aortic arch and bifurcating at C4 into the internal and external carotid arteries. And then we have the right common carotid arising from the subclavian arteries and also bifurcating into the internal and external carotid arteries. Then the internal carotid arteries will supply the brain. So this is just an arteriogram also showing the blood supply. We have the vertebral arteries and we have the subclavian arteries from which the vertebral arteries arise, and then we have the aortic arch here where the left common carotid will arise from, and then we have the subclavian artery where the right common carotid artery will arise. So when we look at the descriptive anatomy, we have the two internal carotid arteries moving superiorly within the carotid sheath and entering the brain via the carotid canal of the temporal bone. And once in the carotid artery, they pass anteriorly through the cavernous sinus, which is shown here. This is the cavernous sinus where the internal carotid arteries pass. And then each internal carotid artery will give rise to the ophthalmic, posterior communicating, anterior choroidal, and anterior cerebral artery. So as we earlier on mentioned, the right and left vertebral arteries arise from the subclavian arteries, and they ascend the posterior aspect of the neck through the foramen transversarum. This is the vertebral artery passing through the foramen transversarum, and it enters the cranial cavity via the foramen magnum and passes medially to the pons. So the vertebral arteries will then branch into the meningeal branch, anterior and posterior spinal artery, as well as the posterior inferior cerebral artery, and then converge to form the basilar artery that will supply the cerebellum and the pons, and it will terminate bifurcating into the posterior cerebral artery. So now we'll look at the circle of Willis, which is here. So the circle of Willis is formed from the anastomosis of the vertebral and internal carotid arteries, and it constitutes of the three paired arteries. So the anterior cerebral artery there, the left and right anterior cerebral artery, and then we have the internal carotid arteries and the posterior cerebral arteries. And then we have the anterior communicating artery there, and then we have the posterior communicating artery. So this is also another diagram just showing us the circle of Willis. So I have the internal carotid, the middle cerebral arteries, the anterior cerebral arteries there, the posterior cerebral arteries, the communicating artery, posterior communicating arteries. Okay, so this is another picture of the circle of Willis. So now we'll look into the arteries in detail to look at the anterior cerebral artery. So the anterior cerebral artery arises from the internal carotid at nearly a right angle. When we look at the previous image here, we have the anterior cerebral arteries arising at almost a right angle from the internal carotid artery. And then it sends deep penetrating branches called the lenticulostriate artery that supply the anterior portions of the basal ganglia. So these are the lenticulostriate arteries that are arising from the anterior cerebral artery to supply the basal ganglia. So from there, the anterior cerebral artery then sweeps forward into the interhemispheric fissure and then runs up over the journal of the corpus callosum before turning backwards along the corpus callosum. And as it runs back, it forms one branch that stays immediately adjacent to the corpus callosum, while a second branch runs into the cingulate gyrus superior to the runs in the cingulate sulcus just superior to the cingulate gyrus. So we have the corpus callosum somewhere there, and then we have this anterior cerebral artery, and then it goes there, and then it runs back along the corpus callosum, and then it provides some adjacent branches that runs in the cingulate sulcus. So now we'll look at the middle cerebral artery. So the initial part of the middle cerebral artery is a single vessel, which is the M1 segment, this one, the M1 segment of the middle cerebral artery. And so the middle cerebral artery has a large diameter and branches at an angle from the internal carotid artery. So after it branches off, it passes laterally just underneath the frontal lobe there, and ultimately taking the position between the temporal and frontal lobes into the lateral sylvian fissure. Okay, so this is also just showing the middle cerebral artery branching off from the internal carotid artery, an acute arm. So as the middle cerebral artery passes laterally, it gives off a series of 6 to 12 lenticulostriate arteries. And these are penetrating arteries that travel directly upward to the brain tissue to supply the large regions of the basal ganglia and the internal capsule. Then we look at the posterior cerebral artery. So as the basilar artery ascends, it bifurcates into the posterior cerebral artery, and its posterior cerebral artery passes around the cerebral peduncles to form short penetrating branches to the midbrain, and then gives a series of long, slender penetrating arteries that supply much of the hypothalamus and the thalamus. So you have the posterior cerebral artery there, which supplies deep penetrating branches to the midbrain. So the cortical branches of the posterior cerebral artery supply the posterior medial parietal lobe and the splenum of the corpus callosum. Yes. Corpus callosum. So supplying the splenum of the corpus callosum, inferior and medial part of the temporal lobe, including the hippocampus and the interhornal cortex, and the medial and inferior surfaces of the occipital lobe. So now we look at the cerebellar arteries. So from each vertebral artery gives off a variable branch, which is the posterior inferior cerebellar artery, which is there, which has a complicated looping course as it swings out around the inferior olives and runs along the dorsolateral surface of the medulla before turning laterally and supplying the inferior surface of the cerebellum. So the basilar artery also proceeds rostral along the surface of the anterior pons and gives rise to additional large arteries, most importantly the anterior inferior cerebellar arteries and the superior cerebellar arteries. So here we can't really see the anterior inferior cerebellar arteries, but you can see this superior cerebellar artery. Then from this image, that's where we can see the anterior cerebellar artery, which is there, branching off from the basilar artery. Also the posterior inferior cerebellar artery is here. So this is just a picture showing the cerebellar arteries supplying the cerebellum. So now we'll look into the clinical applications of this presentation. So the first one is stroke, which is a clinical syndrome consisting of rapidly developing clinical signs of focal disturbance of cerebral function lasting more than 24 hours and defined as transient ischemic attack, which lasts less than 24 hours. So when can a stroke occur? So a stroke can occur when a blood vessel in the brain ruptures and bleeds, or when there's a blockage in the blood supply to the brain. So the two types of stroke that we commonly talk about are ischemic and hemorrhagic stroke. So ischemic stroke representing 85% and hemorrhagic stroke 15%. So ischemic stroke occurs when the blood supply to part of the brain is interrupted and brain cells die due to oxygen and nutrient deprivation. So this is the area, ischemic area, due to a blockage in the blood supply to the brain. So there will be death in the cells in that area. So now we'll look at the specific types of stroke. So like when the anterior cerebral artery is blocked, we have anterior cerebral artery stroke. So this vessel supplies blood to the frontal part of your brain known as the frontal lobe. And so if stroke occurs in this area, you may see leg weakness or difficulty in thinking and making decisions, and there could also be personality changes. So here's the area which is just showing the left anterior cerebral artery stroke. These are also diagrams depicting the stroke occurring in the anterior cerebral artery. Then we have the middle cerebral artery stroke. So the middle cerebral artery supplies blood to the middle part of the brain, and these are the most commonly affected vessels in a stroke. And so if you have stroke in the middle cerebral artery, you have paralysis on one side of the body, changes in sensation, blindness, language problems, and such as difficulty forming words and sentences, and also difficulty understanding what others are saying. So these images showing neural images showing the middle cerebral artery stroke right there, also there. Then you have the posterior cerebral artery stroke, which occurs due to the blockage of the posterior cerebral artery. And if you have stroke in this area, you may notice problems with vision. So here is the area which is affected in the posterior cerebral artery stroke. And these are also clear images showing posterior cerebral artery stroke. So now I'll talk about hemorrhagic stroke. So hemorrhagic stroke occurs due to bleeding into the brain by the rupture of a blood vessel, and he's bleeding into the brain due to rupture of the blood vessel. So how do we manage stroke? So the principles of management, we have supportive management, medical management, and surgical management. So on the supportive management, mainly we look at the airway and vitals of the patient, airway temperature, blood glucose, and blood pressure. Then on the medical management, we can give thrombolytics, especially if the patient comes in early, maybe within 3 hours of the stroke. So we can give thrombolytics such as tissue plasminogen factor. Then we can give antiplatelets such as aspirin, and the anticoagulants, we can give heparin, warfarin. Then we can also do hemodilution and give vasodilators in the case of stroke, and neuroprotective agents can be given. Then on the surgical management, it depends on the type of stroke. So the goals are to combat life-threatening raised intracranial pressure. So we can do decompressive hemicraniectomy. We can do external ventricular drainage and endoscopic or craniotomy for evacuation of the intracerebral hematoma. And then we can clip, wrap, or coil aneurysms to prevent rebleeds, and we can do excision of arteriovenous malformation. Then the other condition we look at is the cerebral aneurysm, which is the dilatation of an artery greater than 50% of its normal diameter. And these aneurysms usually occur in the circle of Willis. You can see here. These are examples of brain aneurysms, of the circular aneurysms, the fusiform aneurysms, and this one is the ruptured aneurysm. So they commonly occur around the circle of Willis. And so blood accumulates in the arachnoid space with a subsequent increase in intracranial pressure. So this is also just an image showing the aneurysm, middle cerebral artery aneurysm. And we have an image showing the dilatation in this artery. So showing a cerebral aneurysm. So on the management of aneurysm, we can clip the ruptured aneurysm to prevent rebleeding. We can do endovascular therapy. So for this one, no incision is made on the skull. Instead, the catheter is pushed up from a blood vessel in the groin into the blood vessels in the brain. But again, the choice of treatment depends on the aneurysm size, the characteristics, location, and comorbidities. So this is showing an image where the aneurysm was clipped. And then these are also various methods. So here's the clipping, and then put stents and wires to. These are some of the ways we can use to manage the cerebral aneurysm. And then the other condition we'll talk about is intracranial hemorrhage. So the types of intracranial hemorrhage that we have epidural, subdural, subarachnoid, and intraparenchymal hemorrhage. So the epidural hemorrhage is bleeding that occurs between the scar and the dura mater. Then we have the subdural hemorrhage, which is a collection of blood between the dura and the arachnoid. And then we have the subarachnoid hemorrhage, which is bleeding between the arachnoid and the pia mater. And then we have the intraparenchymal bleeding, which is bleeding within the brain parenchyma. So this is an image showing the epidural hematoma and the subdural hematoma, showing that the blood from the subdural hematoma is from the venous, venous blood, usually from the bridging veins, and then from the blood, the bleeding from the epidural hematoma is usually from the meningeal artery. And this image is also just trying to differentiate the types of stroke of the epidural hematoma, the subdural hematoma, have the intracerebral hemorrhage, and the subarachnoid hemorrhage. So these are images showing the different how these types of hemorrhage will occur on CT scans. So have the epidural hematoma, then have the subdural, then have the intraventricular hemorrhage, subarachnoid, and yes, subarachnoid hemorrhage. Then as we conclude, it is important to know the arterial supply to the brain and understand the conditions that are associated with it, as this will aid in prompt management for the better outcome of the patient, as most of these conditions are life-threatening and require immediate intervention. So these are my references.
All right. Thank you so much, Musankaya, for the wonderful presentation. It's really well done. So at this point, we are going to entertain questions. So I'm going to go back to the panelists now. We have just listened to this wonderful presentation. I don't know if you have any question. Let's feel free to unmute and ask our question. If you have any question, you can unmute and ask your question directly, or you can decide to just type it in the chat box. Okay, while we wait for others, I just have some few questions to ask. So my first question was, I saw in part of your slide that you mentioned induced hypertension as one of the management of stroke. So I don't know if you can just like explain better how induced hypertension can help. Yeah, this 5 hemodilution vasodilators can induce hypertension. And if possible, like in what category of patient do you like induce hypertension in? Is it all stroke that is it all stroke? I think that's my first question. Then my second question would be that is there a way to like clinically differentiate between all the different types of intracranial hemorrhage? Like clinically, without is there a way to differentiate that when a patient comes in, you'll be able to say, oh, this is probably a subdural and epidural or something. Thank you very much.
Okay. I think I'll start with the last question on how to differentiate the types of stroke. So on the epidural and subdural hematoma, usually with the epidural hematoma, patients reports with a history of loss of consciousness in the epidural hematoma. Then, okay, I didn't really get your question on the induced hypertension. Are you asking how to manage it? Or?
No, I'm just trying to know, like, what's the benefit, like, of inducing hypertension, and like, is it all patients that will really benefit from that? Like, I just want to know, why would you want to induce hypertension?
Let me try and help there. Musakaya, really good presentation. I do realize it's a lot of stuff to take on. I loved your presentation. It was kept simple, and you covered a lot of points. There's still so much, as you know, there's so much now in medicine. The information explosion, knowledge explosion is quite significant. And over the last couple of years, there's even so much. So a few things to highlight. So what is it Tunde who asked the question? Yeah.
Yes, sir. Yes, sir.
Yeah, Tunde. Yeah. So induced hypertension, the best way of looking at it is when you have an injury, and the same concept similar with traumatic brain injury. When there's an insult to the brain, that insult is regarded as a primary brain injury. Okay. And that primary brain injury, you can't really do anything about it. So the only way of preventing primary brain injury, if we look at traumatic brain injury, is prevent the injury. And that's why all over the world, they've reported that with better laws, with legislation, with people wearing helmets, primary brain injury has reduced. Now, our jobs as neurosurgeons is to prevent the effects of secondary brain injury. Secondary brain injury, the things that affect secondary brain injury or the risk factors are things like hypoxia. So on the ICU or as a neurosurgeon, you want to make sure that the brain has oxygen. Hypovolemia, you want to make sure that the brain has good supply, which is what Musakaya was talking about on her first slide. You want to prevent the patient from having seizures. You want to prevent the patient from being diabetic, so you want to keep the blood sugar under control. You want to prevent the patient from having an infection, so you want to keep the temperature normal. So those are the things, that's really the objective of a neurosurgeon or neurologist or neuroanesthetist. So in cases of stroke, especially in the first 72 hours, you want to make sure that the brain has good blood supply. So that's where you trigger induced hypertension. You make sure that there's more blood supply. You raise the MAP, the mean arterial pressure, so that there's more blood supply, especially in ischemic stroke. Now, it's different with hemorrhagic, because that would not necessarily work in hemorrhagic, because if you cause induced hypertension in hemorrhagic, especially if there's an AVM or an aneurysm, then you'll be making the matters worse. So that's the first issue. Now, the reason why I said 72 hours is usually after 72 hours, then there is an established infarct. So if you're still triggering hypertension, then because it's now dead tissue, you can cause more bleed to that part of the brain because it's dead tissue. So some people will say if you're still triggering hypertension, it could cause more harm than good. So that's answering the question of induced hypertension. Now, the question about epidural and subdural, if you go to Musakaya's slide, and I think it's slide 50, Musakaya, can you bring that slide up just so that I could show? There's a really beautiful picture on epidural hematoma. Now, it was 50, I think. Yes, exactly, that one. So if you look at epidurals, epidural hematomas are limited. Epidurals have this convexity, biconvexity picture. And the reason why it's like that is because at the top, the blood cannot go anywhere because of the suture. So the dura is attached to the skull and there are sutural attachments. So the dura goes into the suture. So because it's epidural, it's on top of the dura, but under the skull. It can't go anywhere to the top. Subdurals can spread convexity. They can spread as much as possible. So that's why chronic subdurals in elderly patients are not as bad. But if you have epidural, especially in a young patient, which is arterial from the middle meningeal artery, arteries are spotting out blood. So the blood is just pouring, but it can't go anywhere. It's blocked by the suture at the top. It's blocked by the suture at the bottom. So the only way it can expand is towards the side. So it just spreads to the side. And then it causes herniation. So it's pushing, you can see that uncus. I don't know if you can point to it. If you know what the uncus is, you can see it's pushing on the brainstem. And that's why Musankaya was saying something that with epidurals, you see loss of consciousness because there's something called the reticular formation in the brainstem. So if the brainstem is compromised, the patient will be unconscious. Also on the side of the epidural, there's the third nerve. So when you have that midline shift and it's pressing on the third nerve, the patient will have a fixed and dilated pupil on that side. And if you do not evacuate an epidural on time, most people in developing countries will say you have to evacuate within 4 hours. If you do not evacuate within 4 hours, then the patient is most likely going to die. So epidurals are very dangerous because of the way they expand. Acute subdurals are also dangerous, but because they usually happen more in elderly people where the brain is atrophic and has shrunk down, then sometimes there's more space and you can wait a bit longer before evacuating them. Not all the time, but there are exceptions to the rule, but you can wait a bit longer. Yeah, so that's pretty much answering your two questions.
Oh, wow. Thank you so much, Dr. Vadi. Thank you so much. Yeah. So I think I would just encourage every one of us to ask a question. We have it's an honor to have Dr. Lade with us to help us. If you have any question, please feel free now to ask your question regarding today's presentation.
Don't be shy. Please ask questions. One interesting thing to know is that the circle of Willis is only complete in 20 to 25% of the population. So it's good to know the circle of Willis. The internal carotid artery actually gives about there are 8 branches of the internal carotid, Musankaya. So there are many, much more than the ones that you listed. But always remember that if you have 10 people, only 2 or 3 people will have the complete circle of Willis. Usually in most people, you would have a variant. There will be one part that will be absent or something that's not complete. And it's always good to know the branches. I always say that the internal carotid supplies like 2/3 of the brain, while the vertebral supplies the posterior circulation, the posterior 1/3. And knowing the branches is always a good thing. M1 to M4, A1 to A4, if you're able to read up on it. But yeah, those are the things to remember. Typically, if you have a stroke of the ACA, there's a good picture on, if you Google it, the motor homunculus, so you can see what the ACA supplies. Usually if there's an ACA stroke, the ACA stroke would affect the lower limbs because of the way it supplies the brain. The MCA stroke would affect the upper limbs because of the way it supplies the brain. So it's always good to try and know that. Yeah. Any more questions from anybody for Musankaya as well, or for myself?
Am I allowed to ask?
Yeah, of course.
Yes, I think Tunde also asked, I don't know if he asked, but I also want to ask on how you can differentiate between ischemic and hemorrhagic stroke.
Yeah, so differentiating between both of them clinically is not usually possible clinically. Hemorrhagic stroke usually tends to occur in hypertensives. So most times, if you have a hypertensive patient, you bring a patient to the hospital and the blood pressure is 220 over 120, there's a strong chance it will be what they call it, hemorrhagic. But usually that's why a CT is very important. And when you start treating, usually that's why you have to, because if you don't have a CT, imagine if you're treating, because the treatments are so different. Imagine if you're treating a hemorrhagic stroke, but it's an ischemic stroke. Or let's put it the other way. Imagine you're treating a ischemic stroke and it's a hemorrhagic, because you don't want to give them blood thinning medications, thrombolysis, when it's hemorrhagic. It's just going to make it worse. So CTs are now very important. Whenever you see someone's getting a weakness on one side, you have to do a CT on time. So that's why there's increased morbidity and mortality if you do not have a CT on time, because it's more of like guesswork. So in terms of clinical presentation, apart from blood pressure, it's always a bit different. With hypertensive bleeds, there was a scan that you showed, and it's hypertensive bleeds are most times, not all the time, but most times they are centered on the basal ganglia. And the basal ganglia has posterior limb, which has the corticospinal fibers. So usually if you have a hypertensive patient that has a dense hemiplegia, meaning the power is 0/5, it means that that bleed is typically in the basal ganglia, which is where most hypertensive bleeds occur, hemorrhagic strokes. So you have a patient with a high blood pressure and 0/5 power, which is dense hemiplegia. That's typically, even before you get the CT, usually a hemorrhagic stroke. And that's because of the lenticulostriate blood vessels that you were talking about from the MCA in the basal ganglia. You got that?
Yes, sir. Yes, sir. It's clear. Thank you very much, sir.
I think everybody else is being shy, Sunday. I don't know what's happening. I hope I'm not scaring anybody today by showing up.
I guess so. I guess people have been shy. Do we still have any question? Let's feel free. Don't be shy. Okay. So in the absence of any other question, I think we've had a wonderful presentation today from Kosaya, and I really want to appreciate everyone for your contribution, and especially Dr. Andrew for the wonderful input. Thank you very much, sir. Really appreciate your presence and the input, and we really hope that we'll continually see you more often in our midst. So in the absence of any other question, I think we can call it a day. But I don't know, Darwin, do you have any other thing?
Thank you so much, Tunde. And this was a great presentation from Sakanya. And thank you so much, Dr. Alalade, for being with us today. It's been great having you. Thanks everyone for being here. Please, let's continue having these meetings and attending. It makes a huge difference in terms of our learning and the knowledge levels. I'm sure from here, we're no longer the same, right? So please, let's always make sure that we attend these meetings, and let's be active even in the group. Thank you so much, Tunde, for directing the presentation.
Hello, everyone.
Okay, Bejo, go on.
Okay, thank you very much, Tunde. Before we close the meeting, I just want to, first of all, thank everyone who came here today, and especially Dr. Alalade, who despite his busy schedule, at least make it for us today. So I would love to invite everyone. Please feel free to get to me or Darwin. So in case you're interested in any presentation, there's no like, I don't know, like a limitation to any, like to say that this person is the one presenting. Anyone can present. And I'm always available for those who have been presenting. I'm always available to, you know, check up your presentation, guide you, give you resources so that you can make a great presentation as the one which was done today. So feel free to get to me on WhatsApp. I'm always available. I'm always online. Thank you very much.
All right, everyone. Thank you very much. We'll see you again next week.